Okay, welcome to EMR, the online portion of your EMR class. My name is Michael Purdy. I'm a national certified paramedic. I've been doing this in emergency services for approximately coming up on 16 years now. I've been a paramedic for the past 7 to 8, almost 8 years, involved with various components of emergency services, everything from emergency medical services to the fire department and the rescue squad. Some of you already know me. Some of you are getting to know me, and we'll be working through this class together. What I would like you to do while we're going through these various chapters is go ahead and take notes, write down questions that you have during these online portions, and then when we meet in person, have those notes available of those questions so that we can do a review at the beginning of our in-person sessions. There will also be tests on each of these chapters throughout the course, so please keep track of those notes and review those as we proceed on through. So Chapter 1 is a general overview of the EMS systems and where an EMR provider's role lies within that. Also, we will cover the other components of the various levels of provider in the EMS system. Okay, so an emergency medical responder, or EMR, which is what we are preparing to help you achieve, is often or ideally going to be the first responder arriving on scene of a medical or traumatic emergency. The initial care you provide as an EMR is essential because a lot of times these basic life support functions are what indeed actually make the difference between saving a life or losing a life. The initial care that is provided by you is typically followed up by any of the following. You have EMTs or higher advanced EMTs or paramedics, and then we'll also be handing off care to nurses, nurse practitioners, physicians, or physician's assistants at the hospital later on down the road after transport and handoff. So the EMS system, all the agencies must share a mutual understanding of their roles in the EMS system to operate smoothly. That way, when we arrive on scene, we kind of know what is expected of us in our role and which way to go, left or right, what things we should do. Should we take a leading role or a supportive role or jump right into patient care? And there's various components and levels of advancement for a 911 call or an emergency call. So in the beginning, we start, everything's begins with the initial 911 call or the reporting of the call. That is where someone recognizes that there is an emergency. They pick up the phone, they dial 911, and they report that emergency to your dispatch center. The second phase or second step is the dispatch. This is when the dispatchers in the call taking center analyze the information that is coming into them through the 911 caller, and they decide whether it be through algorithm or their agency's various policies of who to dispatch and who to send. Most times in most counties and places, this is going to include, depending on the nature of the call, the fire department with first responders or rescue squad, and then an EMS unit, whether it be a quick response vehicle or an ambulance, 2 ambulances, or any variation of the same. Move on to the first response. This is typically going to be you. It's going to be emergency medical responders, EMTs. Sometimes it's the ambulance crew, which is an EMT or a paramedic, 2 paramedics, whatever the combination. And sometimes law enforcement arrives on scene. During this phase of initial response, it is imperative for us to perform a good assessment, figure out what's going on, what kind of resources are needed. Is this a life-threatening situation or slightly less life-threatening, emergency or non-emergency? And deciding, do we need to call for more resources, or are we okay with the resources that are already dispatched and coming to us? Or can we actually stand down some resources? Because of the way that ambulances are distributed throughout the response district, sometimes their response can be extended by comparison to the fire departments or other first responders, where first responders and fire departments are typically dispatched locally to their station or their response district. Ambulances can be responding from other parts of the county where it's farther away. And we're also moving now in North Carolina towards a direction where we have various levels of ambulance provider level. So you may have a basic life support ambulance showing up first, that can initiate things like CPR, applying advanced or a AED or external defibrillation device, and provide some airway management, bleeding control, shock control, things like that. And then you have your advanced life support ambulances, which sometimes will respond or arrive on scene first, but they can provide certain medications, more advanced medications. The higher the level of provider service goes, they can initiate and establish IV access, percutaneous cardiac pacing. They can also administer cardiac medications and advanced airway management as well. Arriving on scene, whether it be first or second or last, is evaluating the situation, finding out what you can manage within your scope of practice. Some of the main things there is basic airway management, assisting in ventilation for people who are having a hard time breathing or can't breathe on their own. Hemorrhage control. We can stop the bleed. Prevention, recognition, and treatment of shock, environmental injuries, things like that, that we can actually initiate the reversal treatment of some of those conditions. And then moving on, once we initiate transport and we follow into the next phase of the EMS system, we have hospital care. This is when we arrive to the hospital and we hand the patient off to the nurse, physician, nurse practitioner, physician's assistant, what have you, and we give our report and we hand over care to that higher level. And this is where that ongoing treatment, rather, and investigation into the patient's condition will happen. As part of the EMS system, there are some roles and responsibilities of the public health department, which is loosely attached to EMS. But some of their responsibilities are monitoring restaurant cleanliness, conducting immunization records, determining incident of contagious diseases such as influenza, COVID-19, tuberculosis, hepatitis, and then preventing the incident progression of that disease or the spread of the same. Some of the prevention programs that fire departments and other emergency services departments are partake in is education on car seat installation programs to encourage seatbelt use, alcohol awareness programs to ensure bicycle and motorcycle helmet use and safety, blood pressure screenings. This is something that a lot of EMRs or first responders can do in their community paramedicine type programs. We also have the community paramedics that do a lot of this ongoing in-home health monitoring nowadays. And then we also have diabetes screenings. A lot of times we will get dispatched out to homes simply to check a blood pressure or a blood sugar, which is fine. Just because you call 911 or call for emergency services does not mean you have to have an ambulance and you have to go. So let's talk a little bit about the history of EMS and who we are, where we come from, and why we were developed. Many advances in civilian EMS or emergency medical services follow the progression of the military and their field treatment of casualties and victim care. In the United States in the 1950s and 60s, a lot of transport from home to hospital was conducted by funeral homes, hospital-based transport systems, and then also volunteer rescue squads, which started kind of showing up around that time. It was pretty common back then for a station wagon or a converted bread truck or something of that nature to show up and simply give you a ride to the hospital. You might be on a stretcher, or you may not, and you may receive little to no medical care, pre-hospital medical care during that transport. And then as things evolved and training opportunities became available, pre-hospital care started to progress and become more commonplace. In the early 1970s, the Department of Transportation, or the DOT, developed the national standard curriculum for training EMS providers, and that's where we have the basis of all of our formal education for emergency medical services in the pre-hospital setting now. During the 80s, the use of advanced life support within EMS became a commonplace. That's where we began starting IVs in the field and giving a broader spectrum of medications, which is advancing even to this day. A lot of agencies now are carrying whole blood and other things of that nature, and all kinds of wonderful medications that we use to treat our patient in the field. In January of 2019, the National Highway Traffic Safety Administration of the Department of Transportation, or DOT, released a report titled EMS Agenda of 2050. This is a people-centered vision for the future of EMS and what we expect EMS to evolve to, and what we want out of the emergency medical services by that time. So we have 10 standard components within the EMS system. They include regulation and policy of that system, resource management. It's important to be able to manage your resources so that we're not wasting a lot of equipment on resources, or just don't have enough to begin with. We have human resources and training. That's where our continuing education, we have those monthly trainings that we go over and review and learn new things and new advances within our scope of practice. Transport equipment and systems. You'll see it's pretty commonplace now that we have these power stretchers with the self-loading mechanisms. We're preventing our own injury, making it safer for the patient as well, and increasing the longevity of our careers because we're not putting our bodies through so much strain. And then we have medical and support facilities, increasing the interoperability and communication with those systems, so that we know what they expect from us and they know what to expect from us when we're bringing a patient in. Our communication systems are always a juggling act. There are some advancements, there are some things that don't really seem to help, but it's always a back and forth, and we're learning what works best with our communication systems. Around here, predominantly we use radios still, but we have various different components of radio communications, from what's known as the Viper 800 megahertz series system to UHF, VHF, and then there's analog and digital, and then we have different configurations of those radio systems as well. And that varies from county to county and from system to system. Public information and education is important. Figuring out a way to inform our residents within our response districts and better educate them how to take care of their own health and their other neighbors and family members' health as well. And then we have trauma system and development, and then evaluation. This is how we kind of learn from what we've done and how to tweak what we're going to do in the future to make it better to serve our people. So what are some of the goals in EMR training? We want to be able to effectively evaluate a situation, stabilize a patient. Sometimes they're critically unstable, and our goal is to make them more stable than when we first came into the door or through the door. And treat your patients using a minimum of specialized equipment. Sometimes you may have what you can carry in a jump bag, and that's all you have for an extended period of time. So being competent, comfortable, and familiar with this equipment and these techniques to manage these patients. And then, of course, where there is a supportive role for our EMTs, advanced EMTs, and paramedics, it is impertinent for us to familiarize ourselves with some of their equipment so that we can better assist them on these high acuity or critical calls once they arrive on scene. The ability to improvise, especially in critical situations, is very important. We need to be able to think outside the box, see a situation, recognize that that doesn't fit inside that standard way that we were taught, and be able to mitigate that situation and overcome it, and actually manage it, make it less of an emergency and more of a controlled situation. And then always keep patient safety in mind. Of course, our safety is number one as the provider. Our partner safety is number two. We both want to go home at the end of the day. And then our patient safety is number three. But we also want to go ahead and preemptively mitigate those safety concerns. For example, if we're on a car accident on the side of the road, we might want to move our patient out of the line of traffic and make it more safe for them. If we have a patient that's in a bee's nest and they're allergic to bees, we may want to move them away from the bees and stop that from continuing to occur. And then we also want to provide aid without judgment. That's not part of our job. We don't judge our patients for the decisions that they've made or the situations the situations that they're in. We should provide care in an empathetic and caring manner to everybody that we come in contact with. And then also continuously going over your equipment and familiarizing yourself with the gear and how it works and operates so that you can work smoothly and efficiently when the time really matters to actually use that equipment. So we can respond to all kinds of different areas geographically. Some of us will operate predominantly in urban settings, and those can vary very greatly from the rural setting or even a wilderness setting. And then we may also cross over interchangeably. Regional variations in climate create conditions that affect the situations you encounter and require you to use different skills, different equipment in treating patients. In some areas, and also during different seasons, hypothermia may become more prevalent than, say, in the summertime. And then, of course, keeping up with continuing education and supplemental knowledge and skills, things that you may not necessarily have within your scope of practice or is permissible by your medical direction or medical control, but it increases your understanding of the situations you might walk in so that you can better assist an advanced life support provider or a doctor or even an EMT on scene. Just having that understanding of, hey, this is what's going on with this patient and knowing what you can do within your scope to better their outcome. So in addition to with our roles and responsibilities as an EMR, it is very important for us to respond promptly when dispatched to an emergency call, whether it be traumatic or medical. We want to maintain our body's physical health and our mental health as well. The healthier we are, the better we can respond to the calls that we are dispatched to. We always want to make sure that we maintain our equipment in the state of readiness. That's why it is very important when we arrive on shift, at the beginning of our shift, to go through our trucks, check off the cabinets, go through our equipment, make sure that they're in good functioning order. And then when we're arriving on scene and performing what's called our windshield survey, we want to make sure that the scene is clear of hazards, it is secure and safe. We want to recognize any of those hazards, mitigate them, figure out what needs to be done before proceeding in. And always protect yourself and your partner, and then protect the incident scene and patients from further harm. It's never good for us to accidentally drop a patient or roll them down a hill or let them be struck by a vehicle after being already struck by a vehicle. We also need to be able to recognize what kind of resources we need. Do we need more from the fire department, or do we need more from emergency medical system? Or do we even need some type of specialty rescue from the rescue squad? Are we involved in a wilderness type situation? Are we involved in a technical rescue like confined space, trench, hazmat situations, things like that? We need to be able to make a judgment call, get on the radio, get on the phone, and request those resources. And then gaining access to the patient. When we go through vehicle extrication, we kind of hone in on this a lot, that there's a patient trapped in a vehicle. We're not doing them any good unless we gain access to them. So you'll hear us say that that patient is actively dying until you can lay hands on them and assess that situation. So gaining safe, expeditious access to your patients. And then performing a patient assessment. We actually need to get in there and find out what's going on with our patient. Not just have a casual chit-chat conversation with them. We don't need to be super intense and kind of interrogate them either, but we want to find out quickly what is the situation, what is the emergency, is there an emergency, is there some kind of massive trauma or hemorrhage or something like that. And then of course we want to be reassuring, we want to be confident and caring with our patients so that we can instill some kind of comfort, a sense of comfort in them. And then moving our patients only when necessary. That'll kind of break down into another chapter, another lecture later on, but it basically boils down to, is this life over death kind of move, or can we do we need to stabilize the patients, and do we have time to stabilize the patient before we move them? And then also, as first responders, EMRs arriving on scene, there may be just you, and maybe you and a partner arriving on scene first. We can often utilize bystanders if necessary. If we need the help, we can instruct them of things that we need them to do to help us. And then as additional emergency services resources arrive on scene, we can stand those bystanders down and have them stage off to the side. And then we also need to contain the scene. We need to keep bystanders out of the scene. So not all bystanders necessarily need to be there. Sometimes we have a lot of what we call looky-loos or rubberneckers. And some of those folks just need to keep on moving. And it's part of our job to make sure that we don't have people crowding around us. And then, of course, as EMTs, advanced EMTs, and paramedics arrive on scene, we need to assess them as necessary. And that may be simply as simple as taking a step back and standing on the corner, not too far away, and just letting them do their job until they need help. Also, continuity of patient care. This is something that we need to make sure we maintain that. We can't treat a patient here, get up, walk away, and completely ignore that patient we just left and assume somebody else is going to pick up where we left off. We need to make sure that that patient's care is continuous to the next, an equal certification level or higher than our own. And then, of course, documentation. This is probably my least favorite part of this job, is documentation. If I didn't have to type a chart ever again, I would do this 24/7. I would probably do it all for free as well. But we need to carefully document our patient interactions and what happened on scene, and then follow through with our continuing education so we're up to date with the latest and greatest and latest trends. So talking about documentation, it should be clear, concise, accurate, and it should be aligned with the accepted policies of your organization. This also means that this is how it should be done on scene. So that's the accuracy aspect. When we're documenting, we want to document as objectively as possible. We don't want to really interject our opinion or what we think happened. We want to document what we saw and what we know happened. This provides the basis for the people who Q&A or question and answer our calls or review our calls, to evaluate the quality of care given, not necessarily to see if you're doing something wrong, but maybe something that the agency or a system as a whole might need to change to better the outcome of our patients, or make an operation more streamlined or smooth. So it should include the condition of the patient when they were found, patient's description of the injury. How does the patient describe it to you, not necessarily what you saw? And then what did we do initially or to care for that patient? We want to include our vitals in our documentation, or the patient's vitals, not our own. You can if you want, but make sure you document that these are my vitals and this is the patient's vitals. What kind of treatment did we give to the patient? Was it as simple as putting a Band-Aid on them, or did we actually apply a tourniquet? Did we ventilate the patient? What rate of respirations did we ventilate the patient at? And then, of course, who did we send the patient off to the hospital with? Was there a refusal and the patient stayed at home? What EMS ambulance or agency took that patient, and where did they go to? And then any other helpful information that you know to be fact. So our medical oversight is the person, or usually our medical director, is the person who gives us our standard protocols, our set protocols of what we can do and can't do. They are also our phone a friend when we get into those sticky situations where it doesn't really fit inside the box of our standing orders or standing protocols. So we can always call a physician and talk to them, explain the situation, and be like, hey, doc, I'm at a loss here. I don't know what to do. What do you recommend? And as long as they give you a recommendation that's not grossly outside of your protocols or out of your scope of practice, they can give you guidance on how to treat or mitigate a situation. Every EMS agency or system, including fire departments, has what is called a medical director. This is a physician who directs the training, the type of training, how it's conducted and implemented on the medical side of it. And they have a say-so and an input on policies and procedures when it comes to the medical treatment of patients. They also help ensure quality management of that EMS system and make sure that everyone is adhering to those guidelines and getting the proper training and education. And then, of course, we have this other thing, like I just mentioned, the phone a friend. This is known as online medical control. This can be either over a cell phone, a landline, if those exist anymore, or a radio. And this is where you would call the emergency department to speak with a physician in the ER to kind of figure out these outside of the box questions or situations that you may run into. And then the final component is quality improvement. This is the process that is used to evaluate the effectiveness and safety of the current practices. It includes safety, the effectiveness, patient-centeredness, where we need to keep our priorities revolving around the patient's health and well-being. Our timeliness, how quickly do we respond or promptly? How much time do we spend on scene? Were we on scene for an hour with somebody that needed to be at the hospital 50 minutes ago? Efficiency and equitability. And then finally, after the next various chapters that we're going to be running through, you will receive a certificate that doesn't look too dissimilar to this one here on your screen. And this will be a state recognized, or if you choose to go nationally recognized, you can be dual certified through National Registry and North Carolina State Emergency Medical Responder. So again, I hope you've taken notes, write down some questions that you have so that when we meet in person during our review session, you can bring those back up. We can discuss them as a group and kind of hash through those. If there was anything that kind of confused you during this lecture, like I am confused on a few things, we can kind of unwind that and get some clarity on those things. That's all I have for this chapter. Thank you very much.